we're Clan Bruce. I'm Rydell.
I am Mona.
I'm Anna.
I'm Jake.
I'm Gabriela.
I'm Sam.
I'm Luke.
I'm Brim.
I'm Emanuela.
I'm Anna.
I'm Calvin.
Okay, I will start. So, hello everybody. First of all, we are Clan Bruce, and we are here to present to you our clinical trial. And this is our clinical trials logo. I've personally made it. It represents the two major causes of Crohn's disease. In fact, we can see that the Crohn's disease could be often narrated. So it is symbolized by the DNA, like you can see there. And then it could be due to the fact that the immune system could attack an harmless virus or bacteria. Then, above all that, there's a big red cross. This is why, because a new clinical trial is ready, a new clinical trial prepared by us. So, we are telling you about it.
Our trial is a multi-site phase 2. Oh. So we have a multi-site phase 2 trial of the drug Necronofib versus prednisolone in children aged 13 to 15 with Crohn's disease.
So Crohn's disease is a lifelong condition with the periods of remission and relapse. So that cause inflammation of the digestive system. So the symptoms can include a stomach ache, tiredness, but also blood in the stool and weight loss.
And then the goal of the study is to improve the quality of life, obviously, but more specifically to induce remission in Crohn's patients.
Okay, to participate in the trial, people must be aged 13 to 15 years old, of European descent, live in Britain, and they can be male or female. Patients must only have Crohn's disease, cannot be pregnant, and have access to a hospital. They also can't have any allergies that would affect the trial.
In the trial, there will be 200 participants, and they will be randomly split into 4 groups with different treatments. The trial will be double-blinded.
So one group will receive the prednisolone daily, 30 milligrams, and then the other 3 groups will receive either 25 milligrams, 50 milligrams, or 100 milligrams of the Necronofib drug daily.
So patients will keep a weekly diary in an app to record the symptoms and how the week was. So they will be asked to record how they felt while being reminded about medication and appointment.
So at first for the, sorry, I'm in front of everyone. At first for the patient diary, we were just thinking of just giving notebooks, but then we realized they're teenagers. Teenagers lose things pretty easily, and it's much easier for them to just keep track of everything on a phone. So we made an app instead.
So the first screen would be something like this. It's called Home. So there you have 4 buttons: contact with your doctor, the calendar, how I feel, and my week. So first of all, there's the screen contact, where you have the mail of your doctor, the phone, or even the Skype to contact with him or she if it's a problem.
And then the next one we have is the calendar, which syncs up with your notifications. So if you have a doctor's appointment coming up, it will give you updates, like tell you that your doctor's appointment is coming up like 3 days before, 2 days before, 1 day before, and then it will like remind you until you actually go. It also will remind you to take your medicine every day.
Yeah, and then is how I feel, where you write how you feel this day, for example, Thursday. And then it also reminds you to take your medicine. So here, if you click, there's across and then you have done that. And if it's in case, to visit the clinic.
And then the last page that we have is the week summary. So it gives a summary of the symptoms that you had that week, and that actually automatically sends itself to your doctor at the end of every week so that you don't have to remember.
So besides using the app, the participants will be required to go in to have a quick checkup with the doctor or the research team. So what they'll do there is they'll have their blood drawn and they'll describe what symptoms they felt that month. And then every third visit, they will take an MRI to check for inflammation in the intestines.
This is our leaflet, which contains information on our clinical study. We created it to have an easier way to approach our clients.
So since our participants go from 13 years old to 15, we are also using it as an assignment form. And we decided to do a leaflet so it would be easier for them when it came to reading it. And that way we can make sure they read it and they enjoy it.
This form contains all the information the patients need to participate to our clinical trial. So,
All right. I'm sorry. There we go. When the trial ends, subjects taking steroids will be gradually weaned off the medication, and those taking the Cronafib will be offered the drug until it is licensed.
Then we will do blood tests for monitor the patient during the study. And there are no known side effects. Steroid could have side effects, but not as small doses. So we are so pleased to have presented this our clinical trial. And we thank you for your attention.
Before you go too fast off the stage, stay up this way a little bit. Just quickly. Just quickly. It's all right. It's not over yet. I mean, you've given us so much fantastic information in your presentation. We can help but maybe have one or two things we might want to ask a little bit more about. Pam, do you have any questions you'd like to ask the group?
So how did you decide on your age range for your study, which was 13 to 15?
Well, we thought, first we were planning on making it a 5-year study, and we wanted them to stay in their teenage years. So it seemed best to keep them at younger teenage years, so that as they grow older, they'll still be in teenage years when they finish the study.
Do you think quarterly MRI scans are going to be suitable for the age range that you've chosen?
Oh, I think so. I think 13 is about the age, I guess, where you could sort of sit still through an MRI. I guess it's about 45 minutes to like an hour probably.
So you focused your inclusion criteria on people from European descent. So I just wondered if you wanted to comment on why you'd made that decision.
Yeah, so it said it mostly affects people of European descent on the sheet, so we wanted to keep it in that region. So.
That's it. Thank you very, very much. Cheers.
Hello, our clinical trial hopes to prevent seizures among young patients diagnosed with epilepsy. In this presentation, you will learn about GME, as well as how we aim to reduce its effects.
Epilepsy is a neurological condition that affects the brain and the nervous system. People living with epilepsy have a tendency to have seizures that start in the brain. The brain consists of millions of nerve cells that use electrical signals to control the body's function, senses, and thoughts. If these signals are disrupted, patients may have a seizure.
Juvenile myoclonic epilepsy, JME, usually appears between the ages of 5 and 16. The actual cause of JME is unknown. Possible causes include brain infections, head injury, and complications at birth, which force the baby to receive less oxygen. Many patients have family history of JME, which leads researchers to believe there is an inherited aspect of the disease. The 3 types of seizures that patients typically experience are absence seizures, which appear as daydreaming or zoning out for several seconds. Myoclonic seizures, which appear as jerking movements in the muscles or of the arms or legs. And worst of all, tonic-clonic seizures, which occur when muscles throughout the whole body stiffen and jerk for several minutes.
As our goal for clinical research involved preventing seizures, we looked into what medications were already on the market. A certain drug known as sodium valproate was one of the most common. However, it can only be taken by males, which can become much of a burden for females. This drug can cause damage to an unborn fetus as well as damage to the reproductive organs. It also causes an abundance of side effects, some of which include aggression, confusion, deafness, and many more.
Another medication available for epilepsy is levetiracetam. It could be used in both girls and boys. However, it is less effective than sodium valproate. It has many side effects, including aggression, anorexia, anxiety, cough, depression, diarrhea, dizziness, drowsiness, headache, insomnia, nausea, tremor, rash, and vomiting.
Okay, Hanfodol is the new treatment proposed to reduce the frequency of seizures in epileptic patients.
It's derived from a chemical found in cannabis, and research suggests that it does not include the same neurological effects that make cannabis an abusive drug, so no worries about getting high or something while on that drug.
So our goal for this trial is to find out whether this drug works, basically, whether it reduces seizures in epileptic patients. This stage of the trial is phase 2, so we're looking primarily at safety, but we're also starting to look at efficacy and whether it actually works.
The eligibility criteria of the study focuses on JME patients between the ages of 13 to 16. We chose a slightly older age range because by this point, many patients would have received a diagnosis and experienced more severe seizures. This will be a phase 2 study primarily focused on the safety of the drug, like Oliver said. Previously in phase 1, it was found that a range of 50 to 1,000 milligrams of Hanfodol is safe to consume in adults. So the priority is to find a safe dosage for adolescents that provides the greatest benefits. In the study, there will be 2 arms. The first is the control group, which is comprised of 100 patients who will continue their regular medication, levetiracetam. The second is the experimental group, who will start a baseline dosage of 250 milligrams of Hanfodol.
The total duration of the study will be 180 days, so about 6 months. And by week 8, doctors can evaluate patients and recommend either a lower dose of 50 milligrams or a higher dose of 500 milligrams. By week 16, patients have the opportunity to move to an even higher dosage, which would be 750 milligrams. Hanfodol is compared against levetiracetam instead of a placebo because an existing solution exists, so it would be unethical to take patients off of their medication. The patient will also be expected to self-report symptoms on a daily basis. They should meet with their doctors every 2 weeks to discuss their symptoms and concerns and allow the doctor to perform a physical examination. In addition, monthly EEG scans will be taken.
All right, so to lessen the inconvenience of asking patients to self-report their symptoms on a day-to-day basis, we're introducing a web-based or app-based survey platform, which we will now demonstrate in a video tutorial. So this is just walking through like a patient login portal, and it takes you through some questions that will be asked about the symptoms of epilepsy that they would experience, and yeah, just some different types of questions. I don't know if you guys can read the text, but we will explain why we came up with these questions. And just wait until the end of the video. That's okay. Yeah. So this is question 4, and then there's a submit function, and then they have the contact information of the researchers and doctors in case they have any concerns or issues with their medication.
Okay, yeah, so those questions were asking about different symptoms and the severity of each seizure that the patient may have had on that day. So it asked questions like, did you have any irregular movements in your fingers? Did you doze off for 10 seconds or more? Did you experience overall jerking movements in your body, and for how long? Just so that the doctor can monitor them, because we are primarily concerned with safety in a phase 2 trial, to make sure there are no adverse effects, and to hopefully see a little bit of improvement, but definitely to make sure everyone's doing okay and is being safe.
Phase 1 trials of Hanfodol have been carried out with adults, and as yet, doses of up to 1,000 milligrams have been determined safe for use in adults. So currently, we're unsure how the drug will affect children, which is why we're starting them on the lower dose to begin with.
So let's have a quick recap of our whole presentation and our clinical trial. So overall, our clinical trial aims to prevent the seizures in juvenile myoclonic epilepsy amongst adolescent patients. We are in phase 2, so we will mainly be looking at the safety as well as the efficacy, but that's not a main factor. It's mainly in phase 3, as well as the different doses. We focused on making our materials adolescent-friendly and convenient to access, so our patient information sheet and our virtual check-in. And yeah, that's our patient information sheet right there. You can read it if you want. And yeah, thank you for listening to us and hearing about our clinical trial. If you have any questions, feel free to ask.
So, thank. Okay.
It's supposed to be in the grey box.
Thank you. That was a lovely presentation. I've just got one question, which is, in your protocol, you say that people who are on your leveracetam, they would be eligible for your trial. Why would somebody who was happy on their current treatment go on to your clinical trial? Or is that a question that you've considered?
So instead of a placebo group, we thought we could use those patients if they're willing to participate, because even if they're happy with their current treatment, our future medicine might have fewer side effects, and they might just be interested in helping people in the future by giving us something to compare to in our clinical trial. So we figured instead of having people who weren't on any medication in our trial, because we felt that that would be unfair, we wanted something to compare it to, but so we can develop hopefully a even better medication.
More effective drug, but people on levetiracetam are so. But obviously, people the girls can't take sodium valproate and women can't take sodium valproate. So the point of the trial is to try and find a new drug that is going to maybe that both men and women are going to be able to take, and the side effects are going to be less severe for both genders.
First of all, I just want to say fantastic job. You've done brilliant exercise all week as mini researchers, and I do hope you're going to have a research career because you'll be fantastic. So my question is, when do you intend to get consent of the patients?
Okay, so maybe if the patient discusses with their doctor that they'd be interested in participating, maybe they're looking for less side effects or to try something new, and then at that point, you would give them the consent sheet and go over it with them.
So, yeah, just to echo the comments, I think the presentation so far this morning, I know we're only at number 2, but the standard's getting set very high by everyone, so well done. The question I had was about your study design. It's no way a criticism about your choice of groups, just really interested in how you thought through that process. So you've chosen to kind of have a dose escalation to try and work out an effective dose, rather than having maybe 3 different treatment groups on a set concentration. So I was just interested how you'd kind of come to that decision. What led you to that design idea? And feel free to pass the microphone down this end if anyone down that end wants to go to discuss.
We had contemplated having 3 separate groups of dosages, but we, even just from experience with all of our treatments throughout our lives, we've noticed that it's common to start on a certain dose and adjust depending on symptoms and side effects. And we thought that that would be most effective in especially the adolescents, since there isn't yet a set dose, and there's more confidence in adults.
I think because we don't know how this drug is going to react in the adolescent population, we thought that if we all started them on a single dose that was a fourth of what had been safe for the adult group, they'd all be able to start a certain range, and then depending on their symptoms, we'd be able to adjust that. So I think it was like a baseline, and then, because each person's different and we don't know how they're going to react, so I think to put everybody in a specific group, I don't know if that's even fair, so.
Hello guys, we are the almighty Campbell clan. I'm sure you guys all know our names because it is the last day, so I'm not going to bore you with that. Our drug is called salbutamab. It's treating psoriasis. We're aiming to clear the psoriasis effectively with less side effects as well. And our target audience is young people aged from 16 to 33-year-old who currently have moderate psoriasis. And then after the trial data, we're going to split it up, see if there's any patterns between 16 to 21-year-old and 23-year-old, 23 to 33 years old as well. And yeah, we aim to incorporate the 50 to 60-year-old because there's 2 flare-ups when it comes to psoriasis. There's the initial flare-up when it's 16 to 33, and there's another flare-up 50 to 60. We want to care for the younger people first to prevent psoriasis, when it's longer down the line. Yeah, and we're gonna try because initially our way of medicating will be taking injections. We aim to change the type, change it into a pill because it's much easier. And it is a phase 2 trial, so we're trying to still learn about the drug, make sure it has any side effects, but phase 1 was successful, so yeah.
So in this trial, we're going to be testing our new drug, which is called salbutamab.
As you can see, it's a biologic that can reduce the signs and symptoms of psoriasis by blocking the immune cells that are thought to cause the condition. Like Danny said, it's currently only available by injection. So in our phase 1 trial, there were no known side effects when the subjects were taking 300 milligrams a week. However, we are concerned primarily with safety since this is a phase 2 trial, so we decided that instead of 300 milligrams a week, which is also kind of a lot to inject into yourself, we're going to have 3 groups taking salvitamab, and the first is going to be taking 50 milligrams, and then 100 and 150. And our control group is methotrexate, which is currently used to treat psoriasis.
All right, so what the patient is going to have to do is they're going to have to administer a self-injection. And remember, these patients are going to be 16 to 33, so they should be capable of doing this. And if not, we included a fake link, but there would be a real video in an actual trial that would just show how to self-administer the injection themselves onto their psoriasis. And there would be monthly clinician visits, and however, this is a weekly injection. So they will be doing this on their own, but every month they'll be going to their clinician for a visual examination of their psoriasis, because since this is a very subjective sort of clinical trial, the clinician will then observe the areas, the intensity and the spread of the psoriasis, and they will rate that on a scale given to them on whether it's improving in the patient or not improving at all. And so that's what the monthly clinician visit is for, mainly just for the visual examination. But on their own, every week, the patient will be monitoring their pain scale of whether it's becoming more painful with whatever drug they're given, either the methotrexate or the salvitamab, and they'll rate that on a scale of 1 to 10, from extremely painful or not painful at all. And so it's also telling your clinician whether you have any symptoms at all. There are known symptoms for methotrexate, and that's why we are using the salvitamab to hopefully not have any symptoms at all. But since this is a phase 2 trial, and we had no symptoms in phase 1, we've learned throughout this week that that may not really mean anything at all, that there could be several things that will show up. And so, yeah, and then that's the link to the self-injection, and also you have to inform your clinician that you're working with the monthly visits, what medications you are currently taking, just because we still really have no certainty of what interferes with salvitamab and what symptoms may occur.
So here's some additional information that is important for you as patients, and some considerations for you. So you will keep the same doctor throughout the trial, and hopefully you'll develop a trusting relationship where you can share any possible symptoms or side effects that you've been feeling, even if you might not think that they're related to the drug or your disease or psoriasis. And you will, so this is a double-blind experiment, and so you will not know whether or not you're taking salvitamab, but you will be treated nonetheless, because we also have a trial arm with methotrexate, which is a commonly used medication. And to eliminate any subjectivity or bias, we also have blinded the clinicians, the experimenters. And so you have the ability to withdraw at any point if you feel uncomfortable continuing with the study, and just let your clinician know, and no one will judge you, and you're welcome to. And if you're uncomfortable also with self-injection, we can provide the opportunity for someone to be trained that you trust to do it for you, or you can increase the amount of visits to the clinician, and they can do it for you if you prefer that. And so if you have, because there are monthly clinician visits, and there might be travel costs associated with that, we will compensate you for that. And finally, we have, all your data is private, and we will protect your identity and because psoriasis is a private disease, and we respect you.
Okay, so on our last slide, we pretty much just have all that information she went over in a more organized format. So the front page, we have our invitation, And then the back page of the leaflet, we have, we tried to make all our questions that we think patients would want to know in a more engaging format. Usually when you're designing things, people tend to disengage after 2/3 when it takes up 2/3 of the page. So having a column format makes that a little more engaging for people to read. And yeah, a lot of the questions she went over we want to include. So is this voluntary? What will I have to do? How will I pay for this, etc. So yeah, that pretty much ends our presentation. Thank you.
So, Panel Club, do we have any questions?
Yes, the panel have questions. You're not getting away yet. Thank you once again. Another fantastic presentation. I mean, we kind of knew the standard was going to be this high because we have seen the information sheets and we've seen you working all week. So I'm kind of struck dumb partly. But I've got one question. You talk about safety. It's a safety study. And you say that there was no side effects in the phase 1 trial. But a phase 1 trial is quite short. So have you got any idea of looking for long-term safety effects of being on a biologic? Because it could be on this for a long time.
So what we didn't mention was that in phase 1, we realized that 300 milliliters was the max tolerable amount of salvittamab that an adult could handle. Now we are incorporating later teens, so the administration in milliliters of the dosage groups that we're using is 50, 100, and 150, which are significantly less than the 300. And this is a complete safety and precaution measure. Not only are we incorporating younger people than we had in phase 1, but it's also to create this in a more comfortable manner because tolerable maybe isn't the best ethics-wise to consider in the study. So for phase 2 especially, we feel like this is the best, and if we see improvement with the higher dosage, then we could think about maybe upping the dosage in a phase 3 or 4.
Thank you, team, again. So I was questioning why you chose the patients to be self-injecting. What made you come up with that?
Well, weekly injections would require a lot of clinician visits every week, and those are hard to schedule. And the patient does have the option to have someone else do it. And of course, we'll create a very informative and comprehensive video that will show you how to do it exactly the way that. But yes, I understand that that's hard to control, but we didn't want to scare the patient that they would have to provide a lot of time.
I was intrigued by the naming of your properstabbing.com. It might be slightly misleading in certain parts of the country.
Yeah, I've been offered one of those in Glasgow. So.
All Liverpool.
Yeah. Okay, so I was interested in your selection of age groups. I think it's good that you stratified it out by age, but I was interested in your lower end of inclusion for age range, really. Why draw the line between 15 and 16? So I just wanted to see what the rationale was for starting at 16, essentially.
Mostly for consent purposes, because here in the UK, it's you're an adult when you're 16, or at least in Scotland, and so you can sign the consent form on your own. Yes.
Also because the 50 to 60-year-olds have a lot more medical factors involved in their lives and more illnesses they could be dealing with. So we figured that when younger people are kind of more healthier in their prime at 16 to 33, there would be less interfering factors. Well, like in reality, there's a lot more medical problems with the older people.
Sorry,
I'm not speaking about any of you guys.
I don't mean to cut you off. Yeah, keep going. Sorry. Yeah.
Yeah.
No.
Well, it's just that because these are so different age gaps for this disease, we figured we either stick with one or the other. And so if we stick with the younger one and we can find a cure there, it's just that if we start with the 50 to 60, it might have other factors that influence the study. So if we start with the younger ages, then we won't have some factors that we would if we started with the 50 to 60. But then once we find out something that works for the younger ages, we would infer and then try it on the older ages as well.
Yeah. Thank you very, very much. Cheers, everyone. Yes. So our drug is called kidneystone, and it's for preventing relapses in patients who have nephrotic syndrome. What is nephrotic syndrome? It's a condition that causes the kidneys to leak large amounts of protein into the urine. Kidneys are damaged and unable to act as a barrier to important proteins that help to protect the body and keep everything functioning properly. It is a rare condition, and with periods of remission and relapse, and that's what we are concerned with.
Okay, so the signs and symptoms of nephrotic syndrome are swelling, which can be observed in the eyes, the lower legs, and the rest of the body. And infections are common as well because antibodies, which are specialized proteins, are lost in the urine, which increases the risk of infection. Also, there can be changes in the urine as well, as high levels of protein cause the urine to be frothy, and patients may feel fatigued and loss of appetite as well.
Okay, and there's a need for treatment because when patients contract upper respiratory tract infections, which are very common, then they tend to relapse afterwards. And there's currently there's no prevention for that. So it would really help to improve patient well-being if they could try and prevent that with a new drug. Okay.
So our new treatment is kidneystone. It's a medicine that in phase 2 trials suggests that can prevent relapse of nephrotic syndrome when you have an upper respiratory tract infection. And it will be taken orally and will be taken twice a week with 35 milligram tablets.
So the objective of our study, it's a phase 3 study, is to find out if kidneystone prevents relapse in patients who are in remission with nephrotic syndrome and have an upper respiratory tract infection.
On the next one. Oh, it's eligibility. Okay, it's for patients between 5 and 16 years old, and they must have nephrotic syndrome, but they have to be in remission. So therefore, they have to have minimal symptoms. So that means minimal swelling of their eyes and legs, and minimum protein levels in their urine. And they should have no other major diseases or illnesses. So also they shouldn't be taking, any medicines. And they shouldn't be pregnant if they're a woman.
So we decided to have 2 different groups. The first group would have the active drug, and they would take 35 milligrams twice a week. And then the group 2 would just be the placebo. And so since the population we're looking for is so specific, we decided to have 1,000 patients overall. With a 2-to-1 ratio, randomization ratio, so 660 patients in group 1 with the active drug and 330 with the placebo. And we thought having the higher ratio of the active drug would increase the chance of participation in our trial.
So for the study procedures, we would provide a urine dipstick to participants to test urine every second day, and they would update anonymous digital diary accessible to the researcher.
We have created this personal diary to collect information about the patient's compliance to the therapy. That means if the patient is taking the drug on the right day at the right time, and to register any type of side effects. It's important to fill in the diary regularly, and it can be completed by the patient or the caregiver.
So we've designed it in a paper form, but as in the future we can, our idea was to build like an application. It has different pages. So personal details page, and even notes, the dosage, which is 35 milligrams for twice a week, and even multiple choice questions about the gender of the patient in that week or day. And even the symptoms, which are multiple choice. It's like a network to the doctor and the researcher, so it can be updated daily for the symptoms that the patient has.
So first for recruitment, we decided that we could look at a registry of all the patients who have nephrotic syndrome. And then by where they are in location, we could use ads and flyers to a link to a website where they can find our patient information sheet. So this website will have information for the parents, like on parent level, and then we would have another section of it for teens, and then the one we focused on was for ages 5 to 8, and that would be a comic. And on this website where the parents are, there would be a link to this comic.
When they open the comic, they'll be able to pick their own character. And after they pick their own character, the next slide would show all the professionals that they would have there, such as the doctors, nurses, and researchers. After that, they'll go through the stages of the 6-month trial, like meeting with the doctor, the blood draw in the collection cup, and then the final result. At the end, it'll say, once you have made your decision, please contact your doctor, and then it'll have more information about how to proceed with the trial.
There were some safety and ethical things to think about. One is, since we're looking at relapse, is if a patient does relapse, when should they be released from the study so they can receive the typical treatment that goes along with that. We also, since this is a phase 3 trial, this is the first time that we'll be looking at the more uncommon side effects, and we need to have plans in place for anything that could come up. Since also this is an international study, we need to have research doctors available all the time, and they can look at the participant record information in the digital diary, which will allow them to monitor treatment and possible side effects. Thank you.
Thank you. I'm starting to sound quite repetitive, but thank you once again for a fantastic presentation. I really liked your consideration of your safety and your ethical aspects, and the consideration of relapse. I mean, I think that's really kind of a mature thing to have considered. With regards to your recruitment, I wasn't clear from your protocol. Are you're recruiting patients with nephrotic syndrome, and then are you waiting until they have a cold, and then trying to get them into your trial and onto your trial very quickly? Or are you going to recruit the patients into your trial with nephrotic syndrome, and then if they have a cold, they go into treatment?
Yeah, so for this trial, it said that they have to have nephrotic syndrome as well as an upper respiratory tract infection. So we'll have them, we'll probably catch them when they have nephrotic syndrome, and then as soon as they develop an upper respiratory tract infection, we'll recruit them in.
Thank you again. I just have one question. So you mentioned using dipsticks to test urine. Do you plan on training the patients to do that at home?
Yeah, we were thinking of having some kind of, along with the patient information sheet, instructions on, and probably when they were provided, to be provided with instructions on appropriate usage.
Again, feel free to pass the microphone down the line if anyone else wants to join in for any questions, feel free. One question I had was about how long you'd be treating the patients for. Would it just be until the signs of the respiratory infection had cleared up, or was it all going to be a set period of time on the treatment for all patients? You're the team leader, nominate, just throw the microphone at someone, take control. Yes. You can huddle and discuss an answer and then nominate a spokesperson. University challenge rules apply for those of you watching the challenge. I may not have judged my audience well here. question is, how are you going to treat your patients for? Is it going to be until the symptoms have resolved, or are you going to treat all patients on a set duration of treatment, even if their upper respiratory infection clears up after 1 week, they still on treatment for a month? How long does your treatment last for?
Well, the idea was to keep them on the treatment for the entire duration of the trial, to make sure.
Okay, hello everyone. We are Clan MacLeod, and we'll be talking about our trial for Macure, which is a new drug for the treatment of bronchiolitis. And this is the logo that we've come up with for our drug. Okay.
So bronchiolitis is a common respiratory tract infection and the blockage of the small airways in the lung. So it affects babies less than 2 years old. Symptoms may include fever, cough, runny nose, high temperature, and difficulty feeding. Around 1 in 3 babies will develop bronchiolitis in their life. It mostly spread during winter, November to March, and the diagnosis is typically made by chest X-ray, and 1% of these babies with this condition die.
You might ask, why is there a need for this new treatment? Because by the age of 2, almost all infants will have been infected with the virus, and up to half of these will have had the symptoms of bronchiolitis. Additionally, 2 to 3% of the babies who develop bronchiolitis during the first year of life will need to be admitted to the hospital because of an increase in the hospital, in the severity of their symptoms. So therefore, finding a cure where there is not one currently is a pressing issue.
So recently, we are hopeful that we have discovered a cure for bronchiolitis called Macure. And Macure is to be administered twice a day in the form of syrup. And recovery is assessed by the child returning to normal behavior, such as feeding normally, displaying alertness, and presenting an increase in oxygen saturation to 90%.
Clan MacLeod is running the clinical trial. The lead doctor, Dr. MacLeod, in charge of trial management. We aim to study the effectiveness of our new drug, Macure, in shortening the duration of symptoms associated with bronchiolitis. The trial will run over the course of a 2-year period with individual patient-family participation spanning over a time period of roughly 2 weeks or the duration of the child's illness.
So we've also thought about how are we going to let the parents know about this trial. We know that the affected group by this condition is children below the age of 2, so our information should be given to the parents. That will be at the doctor appointments, where the doctor will be the one who will explain everything to the parent by showing them a video, and our information sheet will be in the form of a leaflet. It will be colorful, but every color and image that will be inside the leaflet is to be in regards with the information inside. We have a catchy logo and a catchy name, so we think that parents who have children with bronchiolitis will be interested to take part in the trial.
So with our trial, we will be declining participation to any patients who become seriously ill with bronchiolitis and are hospitalized due to patient safety concerns. As our study pertains specifically to children under the age of 2, we'll also be excluding children over the age of 2, and we'll also be excluding babies that were born prematurely or babies with pre-existing heart or lung conditions. The clinical trial will begin with the parent or guardian receiving a leaflet when they realize their baby is showing signs of bronchiolitis, ideally around day 3 of the baby developing the illness. The timeline is listed within our leaflet of what they kind of need to follow. So step 1 is noticing symptoms of bronchiolitis in the child. Step 2 is hearing about the trial through your doctor. Step 3 would be to read the patient information pamphlet and then contact your doctor to confirm your interest. And then at that, when you phone them to confirm your interest, you would make a baseline appointment. They can then send additional information to the family so they can confirm patient interest. And at the baseline appointment, they'll receive comprehensive information, the consent form, and the medicine and instructions.
During the trial, a third of the babies involved will receive Macure, a third will receive a placebo, and a third will be treated as they would currently, like a common cold. If the patients will not be aware if their child has the placebo, Macure, but they will be able to infer if their child's being treated like they would currently. The doctor will know to which group each child falls, as they can assess the results in real time. We will ask the patients to record their symptoms on an app in order to collect accurate and immediate information.
Okay, so every measure will be taken to ensure that our patients are treated safely. And so although we would hope that all of our patients can stay in the trial for the entire duration, we'll make it very clear that they can withdraw at any point for whatever reason with no explanation needed. Also, by consenting to our trial, the parents are agreeing to allow Clan MacLeod to store the child's information, such as name, age, and symptoms, which will only be accessed by medical professionals and used for the purpose of this trial. We take the safety of all of our participants very seriously and have put many safety measures in place. If there were any emergency situations or if the condition of the child was worsening over the course of the trial, we've implemented a 24-hour hotline that parents can contact regarding the health of their child.
The ethics of this project is like, I'm sorry, I wasn't in this part. I wasn't able to be part of this. I had to go to my room for emergency reason. So, there you go. Thank you.
Thank you once again. Another excellent talk and really excellent information that you've provided us already. I'm intrigued as to your inclusion criteria. When only a small number of babies become very unwell and require treatment, why have you excluded the children who are most likely to become very unwell, which is your premature babies? And also, are you envisaging doing this in people's homes, or are all these babies going to be in hospital?
So we're planning on it being done at home where possible. We thought that if the babies were ending up being admitted to hospital, then it could be an excess stress for the parents if they were still in the clinical trial. If they were still feeling that they wanted to, they would be able to continue participating. But as there's no proven treatment at the moment, we figured we'd just stick with what currently is the protocol. We excluded the premature babies and the babies that already have lung and heart conditions, because they may be on extra medication or have other symptoms that weren't compatible with our trial and maybe not the drug. And we didn't want to pose an extra risk to the safety of the children.
Thank you again. Just to follow on from that, so you say you are going to be treating the young people at home, the babies at home. Would it not be best, because most of the babies are quite severely ill at the time, would it not be best to treat at hospital, where you can monitor the side effects or, you know, the severity of their condition in the hospital? So
Because only 2 to 3% of the babies that are affected with bronchiolitis in the UK are actually admitted to the hospital, we didn't want to have unnecessary hospital admissions for them, because it's a lot of time for parents who have to stay with them 24/7 because of their age. it also means there's unavailability of hospital beds, and there has to be constant staffing and things for them as well.
Thank you. Good answer.
I think we'll let you off. Have a round of applause. I had questions, but I can find you all at the coffee break as well. That's absolutely fine. So, yeah, thank you very, very much, everyone.
Okay, so we are Clan Wallace. I'm Michelle.
I'm Josie.
I'm Lucia. I'm Natalie.
I'm Laura.
Gotti.
Annabelle.
Megan.
Marta. And this is the Clan Wallace, and we are going to explain our clinical trial, Spiritum.
Okay, so just a quick overview on asthma. Asthma is a common lung condition that affects all ages, but oftentimes starts in childhood, and is caused by swelling of the breathing tubes, and it makes airways very sensitive and narrow, which causes symptoms like wheezing, breathlessness, tight chest, and coughing.
So our research is trying to prove that Spiritum is more effective than existing corticosteroid that usually the patient use. And about our aim is proving that Spiritum is safer in long-term treatment for children.
So our study is a crossover study. So what we're going to do is we're going to have about 3,000 patients. We're going to have two groups, 1-to-1 ratio, so 1,500 and 1,500. And what's going to happen is for the first 6 months, the first group are going to be on the original asthma inhaler, and then they're going to change to the new Spiritum and reverse for the other group. And it's going to be double-blinded, so the doctors and the patients don't know which one they're starting off with. We are just using, everyone in the study is just going to be in the UK. So we're going to do a multi-centre study, so different centres around the UK. And we decided to do this because with asthma, it can have different triggers. So we did it internationally. Perhaps a dry, hot country would trigger more asthma attacks than somewhere in the UK, so it's not really consistent. So that's why we're sticking with the UK.
Our treatment is supposed to be a 5-year plan, and our trial is a 5-year plan, and treatment is a 1-year plan. 2 years before our treatment, we're doing a research plan, and then right after a year full of treatment, doing what Corey explained. And after our treatment, 2 years of analyzing all of our data to get like a very nice result.
Yeah, so our treatment phase is 1 year, in which every other month the patients will go to the clinic for an appointment, in which they'll take a spirometer test, which is basically a test to see how quickly the lungs can work. So they'll have one appointment at the beginning as a baseline, and then they'll have 3 appointments, and at the 6-month mark, they'll switch from either the old medication to the new medication or the new medication to the old medication, and they'll finish the last 6 months and 3 appointments with the other medication.
All right, so concerning the day-to-day intake of the medication, so we're comparing 2 different medications that have different intake requirements. So the original medication, beclomethasone, is taken twice a day, 2 puffs each, for a total of 400 milligrams. However, the Spiritum, which is the new medication, is only taken once a day for a total of 200 milligrams. So in order to keep this standardized, we've added a placebo inhaler so that in either phase, the patient is taking 2 inhalers a day. So we've added a placebo so that it remains blinded. So half of our participants, we've 3,000 total. 1,500 of them will be in Group A, and the other will be in Group B. But so, for example, Group A would start with the beclomethasone phase, and then switch at 6 months to Spiritum, while Group B would start with Spiritum and switch to beclomethasone. So in this crossover study, they're acting as their own controls, but either way, they're receiving active treatment.
And then finally, for analysis, we would analyze it qualitatively and quantitatively. So qualitatively, we would give the patients a questionnaire form at every clinical visit so that they can fill it in and document how like their symptoms have developed or if they're getting any relief. And then also they would be keeping a personal diary of any irregular episodes or any concerning symptoms that might show up that would be useful to the doctors so that they don't forget it. They would log it down just as soon as it happens. And then quantitatively, as mentioned before, there would be a spirometer test to test the airflow rate from their lungs. And so if we see that their airflow rate increases, then that would show that the medication is working. So, and then we have our patient information sheet here. So does someone want to
Whoa. Okay, so this is our patient information sheet. You've got age at the bottom there, 6 to 11. We've got our wee catchy slogan, stop the attack, fight back, and a wee man playing football. So as you can see, it's not too in detail because we obviously got to stick to that age range. Everything that gets like really complicated, that's going to be in a different one for older parents. So we've got our aim and what will happen. It really is quite a brief overview of what will happen just for these kids to really let them come in. At the bottom left here, you can see the 3-ball spirometer. So that's the game that they would play when they're daily checkups, and like that's quite fun for a 6-year-old to do. And of course, what children are concerned about is will they be safe? So, of course, and we let them know throughout that they will be safe, but if they do want to leave and if they have any concerns, that's fine. There's no worries. They can off they go.
Thank you for your consideration. Does the panel have any questions?
Thank you. I really liked your study design. I liked the way you had a crossover, and you also had a baseline measurement, which is really important. One thing about you mentioned in your information sheet is that you will teach or you will check that they use their inhalers properly. How do you do that? How would you plan to do that?
So as mentioned, on that first checkup, they have their, at the very start of the whole process, they come in and get their baseline checkup. So that's when you would figure out if everyone knows how to do that. And also, people in our study, they've been on their inhalers for over a year. It's not people who have just got asthma. So we're recruiting people who have had it who have been on a reliever for a year. But also, we make exceptions for anyone who has like extreme cases, so it's not strict. But yeah, so they know because they've already taken inhalers before, so it's not a new thing for them.
So I was interested in your patient information sheet, which was lovely, very well presented, and you mentioned safety and wanting to reassure people that they're getting involved in a trial, and kids in particular getting involved in a trial where safety's at the front and foremost. But considering it's still at a trial level, how do you get that balance between a realistic expectation of there being risk and making people feel safe without potentially misleading them thinking it's 100% safe, for example? Does that make sense?
Yep, so I think it's just key to be honest with them and let them know what's actually going on. You can't like pull the wool over their eyes and just say, oh, this is what's happening, you're going to be 100% safe. But because it's in a phase 3 trial and I think one of our main things is we're not taking them off there, we're not giving them a placebo that doesn't work, we're giving them their standardized. So the biggest concern for us was that the Spiritum is non-steroidal, whereas the beclomethasone is. But I know that's all explained. That's just not in the kids one because they don't know that. You know, I mean, they don't need to know. The adults would have that, and they can talk to their child. But a kid doesn't want to read about beclomethasone and non-steroidal and all that.
So that was my follow-on question. So how are you going to encourage parents and the young people to be part of that study if they're already they might be well maintained on the drug that they're already on? What would make them go on to your trial?
So we do put quite a lot of emphasis on the fact that the current one, beclomethasone, is a struggle. It's not that it's an effort. You've got 2 in the morning, 2 at night, and you've got to keep doing that. And doesn't seem to be like helping them with the thing. It seems them maintaining their condition instead of improving it. So we do quite a lot of emphasis on the fact that it's just the one path, and you will improve hopefully with the new medicine.
Thank you.